Hello and welcome to Basics of CAR T, part of the BMT101 CTTC webinar series. I'm Kevin Hay. I'm a hematologist in BC who works with the Leukemia Bone Marrow Transplant group here, and I'll be discussing what CAR T cell therapy is and how it works, as well as a typical patient journey to CAR T and some of the side effects of CAR T and what is done to manage them. So first of all, what is CAR T? Well, CAR T, the T of this stands for T cells, and T cells are a normal part of our immune system that recognizes abnormal cells in the body. Now, these are typically, virally infected cells or early cancer cells, and T cells are very good at clearing off these cells from our body. However, for a cancer to become a cancer, it has developed a mechanism by which it evades the killing by the T cells. So what we do is we redirect the T cell so that it can kill the cancer cell again using this thing called a chimeric antigen receptor. So this is something we put onto the surface of the T cell that we engineer into this T cell to enable it to recognize a cancer cell again. And to do this, it needs to identify some sort of a target on the surface of this cancer cell. So these cells are really made in the lab in a genetically engineered way. And so how this works is we first of all collect T cells from a patient, as you see there on the left. Those cells are then taken over to the lab where this gene, this CAR, is inserted into these T cells, typically using some sort of a vector like a virus that has been inactivated, which means that it's not able to really replicate more than once. It basically can get into that cell once, but it's what we call replication incompetent. Then it makes it so that this new gene gets into those cells, and then we expand those cells in the lab over a number of days to weeks, and then infuse those back into a patient. But before the cells go into a patient, we give some sort of chemotherapy that you see as the number 3 there to enable those cells to properly engraft or really take into the body so the body doesn't reject them. And then once the cells go in, a patient is monitored for a period of time after that therapy for any side effects. So essentially, CAR T is a genetically engineered cell therapy, which has become a living drug. So the drug in this case, so to speak, is the cell product itself, which you see at the bottom there, actually can rise over a period of time after the cells are put into the body, and then subsequently peak and then subsequently decline and go into a bit of a persistence phase afterwards. So what makes an ideal target for CAR T? Well, very basic principles are that it's on all cancer cells and absence of it on non-cancer cells so that we don't get damage to the non-cancer cells in our body. Or if we do have to get rid of some normal cells in our body, that absence of those normal cells is tolerable and manageable. So the most, furthest advances with CAR T cell therapy have been really targeting 2 different antigens, something called CD19 on the surface of B cell cancers, such as, B cell, diffuse large B cell lymphoma, B cell acute lymphoblastic leukemia, and BCMA or B cell maturation antigen, which is a target on multiple myeloma. Now, as you can see from these, you would also lose some of your normal B cells, but you'd be able to get rid of all the cancerous cells. And same thing with the myeloma, you would get rid of your normal plasma cells to some degree, but you'd also be able to get rid of the myeloma. And so your body can live really without plasma cells or B cells. And so this is what makes these relatively good targets. Now, there are many different products at various stages of approval. As I've mentioned, CD19 and BCMA are the furthest advanced along this way. But this lecture won't really cover all the products and indications. And I would encourage you to talk to your hematologist, oncologist about whether products for CAR T are right for you at that current point in time. So let's move on to talking about, well, what is a typical patient journey to CAR T? Well, it starts first of all with identifying the appropriate patient. Now, typically at this current state, CAR T cell therapy is reserved for patients in whom chemotherapy has not worked, which something we call refractory disease or primary refractory disease, or those that have disease that keeps coming back, so relapse disease that keeps on relapsing. Now, research is being done in order to put CAR T earlier in the treatment course for patients, and there is a fast pace, as I mentioned already, of new indications and targets, and really your hematologist, oncologist would be the best person to know if there's a CAR T available for your disease, and if so, at what time it is most appropriate to consider CAR T. Once a patient has been identified that they're appropriate for CAR T cell therapy, they are then referred to a specialized center in Canada that has experience in doing CAR T cell therapy. So these are typically sites that do bone marrow transplant because that's where this expertise in administering cells as a therapy is located. And so a patient will need referral to and evaluation by a CAR T expert. If the CAR T center deems that the patient is a candidate, the center then will arrange for a procedure called leukapheresis, which you see is that machine on the left-hand side there beside the patient, in order to collect the T cells to start the manufacturing process. Now, with current ways of making CAR T cells, it takes approximately 2 to 4 weeks or more, sometimes 6 weeks, to make CAR T cells in the lab and go through this whole process of where we get that gene into the T cells and expand them. So during this time for the patient, from the patient perspective, the most important thing to do is to really keep the disease under control for long enough to buy time until these cells are made and until we can give them into the patient. Therefore, bridging therapy with some sort of chemotherapy or radiation may be suggested by the CAR T cell expert or your hematologist oncologist. And the reason for this, as I mentioned, is to really keep things under control, to give you those weeks so that we can actually get the cells into your body. So once the CAR T cells are confirmed to be made and plans are in place for the infusion, the CAR T cell physician will arrange for something called lymphodepleting chemotherapy to be given prior to the CAR T cell infusion. Now, the reasons for this immunosuppressive or lymphodepleting chemotherapy are really mainly twofold. One, this chemotherapy has been shown in multiple trials to help the CAR T cells expand and engraft in the body. And some early studies of CAR T cell therapy where they didn't give chemotherapy beforehand showed that the CAR T cells didn't take as well in the body and they didn't really grow and expand like we wanted them to. The other thing it does is it helps prevent rejection of these specialized cells by the body, because the body can sometimes recognize these CAR T cells as being slightly different than what it is used to and will try to get rid of them. And so this really lymphodepleting chemotherapy helps prevent this from happening. Now, a typical regimen of chemotherapy for lymphodepletion involves cyclophosphamide and fludarabine, two commonly used drugs in treating lymphomas and leukemias. After those lymphodepleting chemotherapy is given, the CAR T cells are infused. This is actually a fairly anticlimactic thing for the cells to actually go in. It's done rather quickly over a period of less than 30 minutes often, and it's given just like a transfusion in through a line into your body and through the IV. It can be done as an inpatient or outpatient, which depends a bit on what that product is and also what the center is and in terms of how they're set up to do CAR T cell therapy. But it's important to know that what we mean by outpatient still means at a center with good resources, CAR T cell experience, and ability to admit to hospital very quickly if needed. We then move on to really the acute phase of CAR T cell therapy, which is really within the first month or so after CAR T cells. So during the first 2 weeks that these cells are in the body, the CAR T cells expand rapidly in the body and make an army of cells to kill off the cancer cells. Because what's happening here is that these CAR T cells are recognizing these cancer cells. They're being stimulated by that. And that stimulation does a number of things. One of it is it kills off the cancer cell. But the other thing is it says, hey, we need to make more of us to kill off the rest of these cells. And so they expand, multiple folds, 100 to 1,000 fold in the body from what we give initially. And the typical peak of this is about 7 to 10 days after the infusion. During this time, while these CAR T cells are rapidly expanding, the CAR T team will really be monitoring for acute side effects. And the two really I want to mention that are of significance are cytokine release syndrome, or CRS, and immune effector cell associated neurotoxicity syndrome. It's a big long name. We use ICANS instead, or you can just call it neurotoxicity. So let's talk about CRS first. What is CRS? Well, CRS is a super physiologic activation of the immune system. So basically what is happening is that this immune system that hasn't been responding to the cancer is suddenly turned on, and turned on really, much higher than it has ever been before. So it's characterized by having a lot of fevers, some low blood pressure, and difficulty breathing, which is driven by these cytokines, which are the little molecules that cells use to talk to each other, because there's a lot of these that are being released, in some cases thousands fold compared to what normally are in the blood. And so, in milder version of CRS, patients will have, fevers, chills, shakes. They'll kind of feel like they have a flu, but it can get severe to the point where the blood pressure lowers too much that we need to admit somebody to the ICU to get blood pressure support, or they have difficulty supporting their own breathing and we need to help them with their breathing by, putting down a breathing tube, etc. So that severity of illness really only happens in about 10% or so of people. We have a drug we can use to treat CRS. It's called tocilizumab, which is a what's called an anti-IL-6 receptor antibody. IL-6 is one of these cytokines. It's very high levels in the body of patients who have CRS. And so basically what it is it blocks this pathway. And so people's fevers go away fairly quickly and the blood pressure gets better. And most patients respond to 1 or 2 doses. Sometimes people need 3 or 4 doses. It seems to be fairly well tolerated, doesn't seem to appear to alter how well the CAR T cells work. Sometimes we also add on steroids to help with CRS because we need a little bit of the immune system to be suppressed a bit, so it's not so active. And patients will typically recover with no long-term issues from CRS often. What is this neurotoxicity thing, this ICANS? Well, it can actually be almost any sort of neurologic symptom after CAR T cells. The earliest kind of things or signs that we can see is people start to get some tremors, or they can have difficulty writing. The other thing we do is we do this thing called the ICE score that you see on the right-hand side of my screen here, which is basically a very simple series of questions we ask every day when somebody's admitted with CAR T cell therapy, talking about things like orientation, are they able to know what year, month, city, what hospital they're in, naming objects, following commands, writing a sentence, these types of things. And actually, this is a fairly good way of noticing early on if somebody's starting to lose some of their ability to remember things, or some of their ability to do simple commands that might be linked to neurotoxicity. Now, severe symptoms tend to occur in less than 10% of people, and there can occasionally, rarely, be seizures or coma, which can be quite scary. Treatment is with high-dose steroids for this. The tocilizumab doesn't work as well, so we tend to use high doses of steroids. One good thing, though, is that the people who recover from this, and the vast majority of people do recover, there tends to be no long-term neurologic issues due to this neurotoxicity. So although it can be quite a scary time period for both patients and families, the people who undergo it tend to recover, and there doesn't seem to be, at least from what we've seen so far, any long-term issues with, ability to think clearly, etc. So what happens after that kind of acute period of CAR T cell therapy? Well, a disease reassessment is often done around day 28 or 30 by the CAR T cell center. And at this point in time, the CAR T expert will make some recommendations to your community hematologist or oncologist. And depending upon the setup and what specific region of Canada you're in, the CAR T cell center may want to see the patient once in a while afterwards. So for example, a typical schedule might be month 3, 6, and 1 year after CAR T. What is important for you to know is that Health Canada actually mandates that the CAR T centers collect data on how well a patient does for up to 15 years. So the CAR T center will still likely need to be collecting some information on how well you're doing after CAR T. And the reason Health Canada mandates that is because these are such early experiences with this therapy. These are fairly recently approved products, and they are, genetically engineered therapies. And so we really want to see and collect long-term data on how well people do, up to 15 years to ensure that there's no untoward toxicities that we didn't know about. So far, from the data from the US, it doesn't seem like this has played out as a significant concern, but really we're not up to 15 years yet or past that. So it'll be, it's really important to still do this. So after the first, 30 days, one common question I get is, well, what kind of side effects could still be persisting then? Well, one of the main ones is that the immune system, both due to the lymphodepleting chemotherapy received, as well as the CAR T cells themselves, might be weak for a period of time. I typically tell patients, 6 months to a year or so after the CAR T cell therapy, they should really view themselves as a bit immunocompromised because the immune system is really still trying to recover. Now, part of this is also due to the fact that they're recovering from the disease, which is often very immunosuppressive. These lymphomas and leukemias are very immunosuppressive, and also all the chemo they've previously received. But we also think that some of this is due to the CAR T cells themselves specifically. So the best example here is the CD19 CAR T cells, which are the most advanced. They do suppress one arm of the immune system, i.e. the B cells. So long as you have these CAR T cells still in your body that are killing off any potential lymphoma or leukemia cells that might pop up, these B cells will also be suppressed. So infections or suspected infections really should be taken seriously, especially during this year after CAR T cell therapy. Another side effect is really low blood cell counts after CAR T cells, and they can persist for months, and sometimes needing transfusion support or a medication, something called GCSF or filgrastim, in order to support the white blood cell count so that you have enough, white blood cells, red blood cells, platelets, etc., so that you can be safe. So what are some things to manage these side effects in terms of the immune system? I kind of already mentioned what can be done about the low blood counts, but for the immune system, often patients will leave on a antiviral pill like valganciclovir, which is given to prevent shingles, Septra or a similar antibiotic given to prevent a specific pneumonia that can affect people who are immunocompromised, something called PJP. And depending upon where you are and what you've experienced in terms of infections, etc., you may or may not be a candidate for something called intravenous immunoglobulin or IVIG from healthy donors. So this would be in order to support your immune system, but this is not for everybody, and this would be discussed with your CAR T expert as well as primary hematologist oncologist. Most places these days are recommending a revaccination starting 6 months or later after CAR T cell therapy, as immunity may have waned to previous things that you have been vaccinated for in the past, including childhood vaccines. Although most places are in Canada really are starting to try to figure out what to do with this, and this may change. This recommendation may change in the future. So in summary, CAR T cells are a genetically engineered immune cell therapy, enabling the immune system to recognize and kill cancer cells. After being deemed a candidate, patients typically undergo this procedure called leukapheresis, then receive bridging therapy if needed while this CAR T product is being made. They then receive a lymphodepleting chemotherapy, the CAR T cell infusion itself, and then have some sort of more intense monitoring with those first 30 days close to a CAR T cell center of expertise, really to monitor for these things called CRS and ICANS, and then will require some longer term follow-up. Common acute toxicities, as I mentioned, within that acute phase are CRS and ICANS, and longer term side effects within a year are low blood counts and low immune systems. Thank you very much for listening to the presentation.